Okay, thank you very much, and thank you to Samir, thank you to the organisers for asking me to talk, and I'm very happy to give you this update on cryptococcal meningitis. Now, of course, those of you who stay and work in the UK are not going to see so many of these cases nowadays, but all the more important that you get it right when you do see them. On the other hand, if you travel abroad, and especially if you go to Southern and Eastern Africa, you'll realise that cryptococcal meningitis is an ongoing epidemic of a proportion far out of scale of the ongoing epidemic of Ebola virus in West Africa. And we'll talk about the burden of cryptococcal disease in sub-Saharan Africa a bit later in the talk. So plan of my talk, I'm going to deal with the current management first, diagnosis, antifungal therapy, management of complications, and this issue of best timing of antiretroviral therapy in the setting of cryptococcal meningitis, then talk about the future directions, the latest trends in the epidemiology, and attempts to reduce the burden of cryptococcal disease through earlier diagnosis, prevention strategies, through antifungal regimens which are sustainable and suitable for resource-limited settings. And then if we've got time, just a couple of slides at the end about more novel strategies. So what about diagnosis? Liz just alluded to this new lateral flow test for detecting cryptococcal antigen. And I'd like to emphasize that I do think this is a very significant advance in our diagnosis of cryptococcal disease. And obviously this is an incredibly easy format designed for rollout across global rollout to the areas of highest cryptococcal burden. It's incredibly simple, it's a straightforward 10-minute dipstick test. But the second point I'd like to make about it is, although it was designed for a global rollout, it's also got advantages in our own setting in the UK. So there's no excuse about not testing for cryptococcal infection out of hours in patients with lymphocytic meningitis. This takes no time at all, even compared to the latex agglutination test. And moreover, not only is it an easy formatted test, it's actually a better test. And this just shows you the data that shows you that the sensitivity of this test for the cryptococcal glucuronoxylum is orders of magnitude higher than with the latex agglutination. This is latex agglutination. This is the nanograms per mil of polysaccharide that's detectable. This is the prototype test, and it's, as you see, and across the serotypes of cryptococcal infection. So it's not only an easier test to use, it's also a better test. So what about, so diagnosis certainly shouldn't be a problem in our setting in the UK. What about antifungal therapy? Well, you should be aware that this hasn't changed. So even if you haven't been keeping up to date, you haven't lost out, because our gold standard remains amphotericin B plus flucytosine for the initial 2 weeks induction treatment. Of course, it was based on this landmark mycosis study group trial from the New England Journal, 1997, Charlie van der Horst leading. The regimen was supported by our own work from Thailand, where we started to look at the rate of clearance of infection as an endpoint in cryptococcal with cryptococcal therapies, and we showed that this combination leads to the most rapid clearance of infection from the CSF. But importantly, most recently, this landmark study by Jeremy Day and colleagues in Vietnam, for the first time showing beyond doubt a survival advantage for amphotericin B and flucytosine over amphotericin B alone. So that's an important study. It was a 3-arm study, ampho alone, ampho plus flucytosine, ampho plus fluconazole, 2 clinical endpoints, about 300 patients enrolled in the New England Journal in 2013. These show you the survival curves. So this is ampho and flucytosine having improved survival at 2 and 10 weeks compared to ampho alone. The only point I'd make is, additionally, is that this is a very significant effect. The hazard ratio at 10 weeks is 0.6 for the combination over ampho alone. That's a 40% reduction in mortality. That's a very significant effect. So there's no doubt that this does remain our gold standard therapy. Of course, there are practical issues about the toxicities of this combination, and it's got to be given carefully, and this shouldn't be taken lightly, even in our fortunate situation of all the resources we have. You've got to give your saline and fluid loading with amphotericin B to reduce the nephrotoxicity. You should give preemptive potassium and magnesium replacement, and it's got to be carefully monitored with rapid response to any abnormalities for the renal function, the electrolytes, and the anemia. What about the complications of cryptococcal meningitis? Above all, this is raised CSF opening pressure and cryptococcal immune reconstitution syndrome. And together with that, wrapped up with that, what's the best time to start antiretroviral therapy? Well, what about pressure? The best data, the original data that really showed that this raised CSF pressure was a significant problem in cryptococcal disease came out of that Van der Horst mycosis study group trial, and they analyzed the pressure data from that. Dick Graybill's paper some years later in CID. A third of patients nearly having very significantly raised pressure over 35 centimeters. Remember, the normal is 12. High pressure is associated with symptomatology. It's associated with increased mortality. You need to have a high fungal burden to have this problem, but that's a necessary but not sufficient condition to develop high pressure. This slide illustrates what we think is going on here. It's a problem of CSF reabsorption at the arachnoid granulations back from the subarachnoid space into the superior sagittal venous sinus here. This is a post-mortem. We did some careful post-mortems in patients in South Africa who dying with high pressure. This shows the granulation tissue, which is normally destroyed in an average post-mortem, is stuffed full of cryptococcal organisms, these little rings. This is a mucicarmine stain. And we were able to show that, very roughly speaking, the number of organisms here correlated with the pressure. The patients get high pressure, they get papilledema, they get false localizing sixth nerve palsies. So it's a mechanical problem, a mechanical blockage. The obvious way to approach this is through careful therapeutic lumbar puncture, and this is what's recommended, and this is what should be done in practice. Ideas, you can look up the latest version of guidelines to give you some guidance. Exactly how you do this, of course, is based on expert opinion, not on any randomized trials about various techniques of managing pressure. But what I would say is it's got to be done carefully. And after every 10 mils that you remove, recheck the pressure, make sure you haven't dropped the pressure too precipitously. And in our own practice, we don't normally remove more than 30 mils at one lumbar puncture. How much you can safely remove, I have to say, is a completely unknown number, and there's no way you can find that in any literature. Any medical therapy for high pressure is not recommended. And another practical point of great importance is that this pressure problem often develops during the second and third weeks of treatment, and it doesn't mean that treatment is failing. The CSF is being sterilized, but the dead organisms, the polysaccharide is gluing up those arachnoid granulations, and you have to tide the patient over the pressure problem whilst the antifungals take their effect in the long term. And of course it does resolve. This issue does resolve in the vast majority of patients if the pressure is managed. And it's interesting actually, because in our data now from, we reanalyzed this, published this recently in CID, it's over 500 patients that we've studied in different centers in Africa using therapeutic lumbar punctures, using repeat lumbar punctures. And it's provocative now that actually the patients who died had a lower pressure than the patients who survived. There is no evidence now of initial high pressure being a bad prognostic factor in the context of aggressive management of high pressure with therapeutic lumbar puncture. What about cryptococcal iris? It's not uncommon in the setting of, iris is not uncommon in the setting of cryptococcal disease. In Tihana's prospective study, 17% of patients. And it's not unlike iris in other situations, a median of 1 month after starting antiretroviral therapy, especially the patients who start with no CD4s and have a rapid bump in CD4s, and it is related to the antigen titer or the CFU count at the time that antiretroviral therapy is started. I'd like to point out that clearly this is a potentially fatal complication, but the prognosis should be better than the original old papers that describe this problem. We know about it now. We can recognize it early, and we should be able to manage it. And it is usually manageable through pressure control, which can be part of iris as well as the acute meningitis presentation, continuing our antifungals and antiretrovirals, carefully investigating for other causes, because it is still a diagnosis of exclusion. And yes, in selected cases who are deteriorating, then steroids are highly effective. Where does it leave us, though, with, in terms of the time to start antiretroviral therapy? Because clearly, you start too early, you're in danger of provoking more serious, more frequent iris reactions. You start too late, these patients are dying week on week with other HIV-related complications. So this is my first question to keep you awake this morning. When would you start antiretroviral therapy in a patient who's presented with cryptococcal meningitis, in terms of the period after the initiation of antifungal treatment? So do you want to vote on that now? Okay, well, that's, that's really interesting to me, because you as a group, you're up for early ART. I'm reading that right, aren't I? Yeah. Yeah. Okay, well, the correct answer is, according to current guidelines, is 3, 4, or 5. My answer is number 3, I have to say, and I'll just show you the data that to support that. The one point I'd like to make about the trials that have been done about antiretroviral timing is that they tell you when not to start, but they don't tell you which is the best time to start. All these trials compare 2 time points. So in terms of crypto, there was this ACGG trial quite early on, Solopa and co, 2 versus 6 weeks. Now this was across OIs, it was mainly pneumocystis. I don't know whether Rob will mention it, but anyway, it came out in favor of an earlier start over the 6-week start. And there were 30-odd crypto patients in this trial, and the data from the crypto patients didn't suggest it was any different particularly from crypto. Obviously, though, it was only modest evidence with those numbers. But if you like, the suggestion from that trial would be, don't wait beyond 6 weeks. Then there was a brave girl called Tariro Makadzange in Harare, Zimbabwe, who studied 3 days versus 10 weeks in the context of fluconazole therapy for cryptomeningitis, and the early patients did very badly. Clearly, this is too early to start antiretroviral therapy in cryptomeningitis. More recently and significantly, David Bulwer has led an NIH ART timing study in Uganda and South Africa comparing early inpatient start, and the median was 8 days, versus a standard outpatient start of 5 weeks. And this trial was stopped early after 180 patients because this group was doing less well. And this is the data, and I mean there's a fairly clear-cut difference there. And this is presumably due to iris reactions. The patients are too ill at 8 days to start antiretroviral therapy. I'll just show you why I think, the current guidelines now say 4 to 6 weeks, and that's, not an unreasonable suggestion, but we as a group are in favor of the 4 weeks, definitely not waiting for the 6 weeks. And it's based on this data, which is uncontrolled data. Again, an analysis of our patients studied in trials who have gone on amphotericin B-based treatment, gone on to ART. When we first started doing these trials, we used to start at about 6 weeks. In the last trial, the median was about 25 days. So we split them by the median time to start. And if you see, the patients who start less than 30 days, the survival curve flattens off a bit sooner than the patients who start between, at 5 or 6 weeks. And this isn't significantly different, but for me it's very provocative. It's exactly what you'd expect. That slightly earlier start is preventing some of those later HIV, non-crypto, but HIV-related deaths. So, as I say, that's why we would be happy with 3 to 4 weeks. Maybe it was a pity David Bulwer didn't study 2 or 3 weeks rather than 8 days, which was too early. All right, so now I'm moving on to talk about the more recent trends in the epidemiology and some future directions for cryptococcal meningitis prevention and treatment. So to kick this off, this is the second question for you, and concerning the global burden of cryptococcal meningitis currently in sub-Saharan Africa. With which of these statements do you most closely agree? Associated deaths about 50,000 per year in sub-Saharan Africa, 3-month mortality 20%, greater than 500,000 deaths a year with a 3-month mortality of 70%, greater than 100,000 deaths, again 70%, 50,000 deaths with 30% or greater than 100,000 deaths, 30% mortality. What do you think is the current burden of cryptococcal disease in sub-Saharan Africa? You vote now. Okay, well I'm with the majority here. I think number 3 is the best answer, and I'll just show you a couple slides to support that. Here we are, yeah. So this is why some of you may have voted for 500,000 deaths a year in sub-Saharan Africa. It's a much quoted study from the CDC group, and it's a little out of date now because, I mean, obviously the work was done probably in 2008, and it did estimate their point estimate was over 500,000 deaths a year associated with cryptococcal meningitis in sub-Saharan Africa. I think the point is, I mean, according to WHO best data, HIV deaths peaked around 2005-6, 2.3 million per year. 2012, it was down to 1.6 million a year. I mean, you know, obviously this was based on a variety of data, but to imagine that crypto is associated with a third of all HIV deaths is a bit of a stretch. And our best data suggests that it is associated probably with 10 to 15% of all HIV deaths. And if you do some rough calculations, that comes out at more like 100,000, 200,000 deaths per year in terms of the current HIV epidemic. But this disease is not going away, and this just shows you how cryptomeningitis is overwhelmingly the most common cause of adult meningitis in many centres in southern and eastern Africa. This is Joe Jarvis's data from Cape Town, thousands of CSFs analysed. This crypto dwarfs the bacterial meningitis, and you know, TB is second. And again, from Kampala, even more marked the fact that crypto is overwhelmingly the cause of adult meningitis in areas of high HIV prevalence. This is 2013. This is not going away, unfortunately. This is surveillance data from South Africa, showing only a modest a decrease in the number of cases in recent years, despite the fact that ARV programs put more and more people on antiretroviral therapy, and of course the ARV program is relatively well developed in South Africa compared with much of sub-Saharan Africa. And in South Africa again, the inpatient mortality stuck at 35% odd inpatient mortality. This is in South Africa, despite the fact that the AMPHO usage they've managed to get it up with the cost reduction of amphotericin B in South Africa. So 35% inpatient mortality, that translates to 10-week mortality well over 50% and a 3-month estimate of 70%. I think that was the original CDC estimate, and I think that's still, unfortunately, a reasonable estimate. This just shows you some epidemiology from outside of South Africa. Emma Wall, working in Blantyre in the Liverpool group, wrote about pneumococcal meningitis. And you have to look in the supplementary figures to find the crypto data. I don't know why, considering it's responsible for 60–70% of all their meningitis. But the fact is they have very good data over a whole 10-year period. There is no decrease, unfortunately, in crypto cases at all in this centre in Malawi, and I think that's the case across sub-Saharan Africa. The difference that is now emerged in the epidemiology is that half of these patients have been not only diagnosed with HIV, they've had ART experience. They've been started at one time or another on antiretroviral therapy. They may still be taking their antiretroviral therapy, but they're failing. They're failing due to, obviously, a mixture of adherence and resistance issues. And that, again, unfortunately, doesn't speak well for the likelihood of crypto going away anytime soon as a problem in HIV-infected patients in sub-Saharan Africa. And in terms of outcome, as I say, not just to re-emphasize the mortality associated with this disease, in Zambia, they used 2 weeks amphotericin B induction in Zambia. Peter Mwaba brought in that policy, but it's in routine use. And even in their referral hospital, UTH in Lusaka, that's 39% in-hospital mortality. So that's not making a big impact in routine use because of the challenges of using it safely. And with fluconazole, the point about fluconazole is the patients keep on dying. This survival curve with fluconazole does not level off. And if you look at the data from fluconazole, even if you go up to 1,200 milligrams a day, the patients keep on dying. At 1 year, you're talking about 22% survival. So there's work to do. So what can we do to try and address this issue? The first thing is about an earlier diagnosis and a preventative strategy. And this is made possible, of course, by that new dipstick point-of-care diagnostic test. As I've told you, most patients now are, when they present with crypto, they've been not only diagnosed with HIV, some of them have even been started on antiretroviral therapy. We should be able to prevent some of these cases if we screen for early cryptococcal infection using the antigen test. And the rationale is based very largely on Joe Jarvis's study from Cape Town, taking advantage of this bank of plasma samples of over 700 patients as they enrolled for antiretroviral therapy in the HIV clinics in Cape Town, and testing them retrospectively for cryptococcal antigen. These were patients who were carefully followed in some of those early ART programs by Linda Gale, Becker and Robin Wood in Cape Town. What he found strikingly was the 5% about of patients who were antigen positive, nearly a third of them developed meningitis in the year of follow-up, whereas none out of 660 patients who tested antigen negative at the time that they enrolled for ART, none of those patients developed meningitis. So it's a highly good test. On this data, perfect negative predictive value. That's what you want for a screening test. So this data provided the rationale for this screening and preemptive treatment. If we treat these patients with subclinical or very mildly clinical symptoms with fluconazole, then in this setting, fluconazole should be effective. And there was different cost effectiveness modeling suggesting this not only saved lives, but actually saved money over the comparison of no screening, and then you have to treat these patients as best you can. That was enough for the WHO in their guidelines. It was enough for the Department of Health, the retrospective data and the cost effectiveness. But we do now need, and we will very shortly get prospective data about whether this screening strategy actually works. And the REMSTART study that we've been involved with Chaba Jaffa is finished now and will report shortly. There's the AUKUS trial going on in Uganda. There's MSF programs. So there's quite a bit of data will come out. There's a lot of work to do about exactly how this screening should be done and how antigen-positive patients should be managed in detail. But I'm convinced of the efficacy of the approach. All right, the other use of the point-of-care test is for making an earlier diagnosis in symptomatic cases across the board. The problem is, of course, headache is pretty non-specific, and a lumbar puncture isn't a very attractive option immediately. So patients' diagnosis gets delayed, and by the time they do go to the central hospital for an LP, it's basically too late. A point-of-care test gives us the possibility of diagnosis even in primary care. Not to say the patient doesn't have to be referred. They still have to be referred to hospital for their lumbar puncture, their pressure management, optimal antifungal management, but there shouldn't be this diagnostic delay. So, of course, the challenge there is to get this test out across sub-Saharan Africa. And the numbers that they've sold is shooting up, but obviously we need donor support in terms of making this test widely available. So moving on now to antifungal regimens, and as I say, we don't have a lot. I've got a slide about new antifungal drugs. There are not a lot of new drugs for cryptomeningitis, but what there is work ongoing that we're involved with is trying to make regimens which are feasibly sustainable in resource-limited settings, as opposed to 2 weeks amphotericin B and flucytosine, which is simply not available or feasible across most of sub-Saharan African hospitals. And as I've said, the current alternative of fluconazole monotherapy is just not good enough. So we have this ongoing MRC-funded phase 3 trial. This is being done in Malawi and Zambia and Cameroon currently. And we're comparing 2 experimental regimens to see if they can approach the efficacy of this aspirational standard of 2 weeks amphotericin B. The first is high-dose fluconazole combined with flucytosine, best oral combination therapy, and the second is short-course amphotericin B-based combination with 1 week of amphotericin B induction. And what we hope is, the potential impact, if either of those experimental regimens did prove as effective as 2 weeks ampho, then the impact could be to reduce the 10-week mortality in all the centers using fluconazole currently from around that 60-odd% mark to the 35 to 40% at least. This is the outcome seen with 2 weeks amphotericin B combination in the sub-Saharan African setting, where patients still come, unfortunately, quite late during the course. If they're not effective, of course, then we have the data, and we know that we simply have to put resources in place to deliver 2 weeks of amphotericin B induction. I don't have time to show you all the rationale, the data that supports the use of those two regimens in a phase 3 study, but this just shows you, I've got a couple of slides. This is about the oral combination, showing that in a phase 2 study in Malawi, patient survival looked, I mean, it was a phase 2 study, not powered for clinical endpoint, but it actually almost reached clinical significance, was improved over fluconazole monotherapy. The rate of clearance was very significantly more rapid with the combination. And this is just about the short course amphotericin B. This is a cohort from Umbarara, Uganda, with Conrad Muzura, and it shows patients the result of the clearance. This is clearance data. This is clearance of the CFUs per mil of CSF over 14 days, with 5 days ampho added to the high-dose fluconazole. The point is that although you only dose for 5 days, the clearance carries on through the second week with no slowing down. The fact is, we know ampho has a huge long half-life, especially in the brain tissues, and the proposal is that once you load up the brain compartment sufficiently, then you have this very prolonged antifungal effect. You don't lose efficacy, you gain on sustainability, less side effects which normally come in during the second week. It makes the whole regimen, of course, much more feasible in resource-limited settings. And there's increasing evidence from this from the preclinical arena, doing it in reverse in a way. William Hope's group in Liverpool have recently published this study that shows exactly the same thing in both the rabbit and the mouse model, that if you load up at the beginning, they used 3 days as it happens, it was equivalent in terms of its antifungal effect compared to daily dosing for 14 days. Okay, just to mention one other approach for the future, with the same goal of increasing the efficacy, building on a backbone of high-dose fluconazole, which of itself is not enough. Joe Jarvis is starting, hopefully next week, to enroll this study, phase 2 study, looking at intermittent high-dose ambisome and measuring, looking at it as it's been used in visceral leishmaniasis, giving 1 or 2 big doses of ambisome on top of fluconazole and looking at the effect on the rate of clearance of infection. And we hope to, we're going to do this in Botswana and also Tanzania. We hope to roll this into a phase 3 study comparing the best scheduling of the high-dose ambisome against standard daily dosing. All right, I did say that there aren't many cryptococcal drugs, and there may be some out there that I don't know about. But of course we need new drugs. We need oral cidal drugs that don't interact with rifampicin and antiretroviral therapy. And there is one potential drug, but this isn't still in preclinical evaluation. But it is being developed specifically for cryptococcal meningitis with the NIH support for their program for drugs for neglected diseases. And preclinically, certainly, it looks interesting. It's concentrated in the brain, it has cidal activity, and it has, in their hands, better activity than fluconazole. All right, meanwhile, we don't have new drugs. We need also to improve the access to our current drugs. And of course, flucytosine is basically currently not available across sub-Saharan Africa. So just to say that there's quite a lot of ongoing advocacy, there's this cryptococcal meningitis action group, to try to advocate. I think our first task is access to flucytosine across Africa and Asia. And there's no reason that flucytosine shouldn't be made by a generic company and made widely available with support from the major donors. All right, I've just got 2 slides to finish up about more blue sky thinking or more directions for the future. I mean, maybe the first is about immunotherapy, and the second is about the virulence of the organism. Maybe immunotherapy is not so much in the future, but this remains of interest. Adjunctive immunotherapy, especially in this HIV setting where the issue is lack of immune response to the to the infection. And what I'd say is that we do now have excellent data from patients about protective immune responses. So this is not animal model data, this is directly from cryptococcal patients. We know what type of immune response is associated with better survival. This again is the work of Joe Jarvis in South Africa, looking at the pattern of cytokine release from PBMCs, specifically the CD4 memory cell subset, stimulated ex vivo with cryptococcal manoprotein. The patients who survived had more of this interferon gamma and TNF producing CD4 cells, including cells producing both, polyfunctional cells producing both cytokines, compared to patients who died who had very few of those cells, their T cell response dominated by cells that were just pouring out MIP-1 alpha chemokine. So of course Joe did also show that adjunctive interferon gamma treatment speeded the rate of clearance of infection. That the challenge really, I think, is now to target that type of therapy to the subgroups of patients who are likely to benefit the most. And secondly, just to mention that there's ongoing work, and we do now have evidence, and this is a paper from Tihana and her group just last year, about what are the virulence factors of this organism that matter in patients. And I mean, she previously worked work on the capsule, but here in this paper showing that the lacase activity of the organism and phagocytosis affect clinical outcome in patients. And obviously, this is at a more early stage of thinking, but maybe we can come up with strategies in the future that target these important virulence attributes of the organism. So I'll finish there. This is just to finish up. This out of interest, these are Mupani trees. This is where crypto hangs out. These are Mupani tree belt in southern and eastern Africa. And Matt Fisher and Tihana and her group have been collecting the cryptos from here. They're going to compare it with the crypto from the patients and find out again more information about what makes this organism kill the HIV-infected patients. All right, those are some acknowledgements. Obviously, there's a lot of work from collaborators across sites in sub-Saharan Africa. I'll be happy to answer any questions if there's time at the end. Yeah.
Thanks very much, John. Yeah.